Hello and welcome to Sharon Regional's Center for Weight Control Information Seminar for Bariatric Surgery. My name is Kendall Kristoff. I am the registered dietitian and the bariatric coordinator here at the center. The goal of this seminar is to cover the following topics. What is obesity? What are the consequences of morbid obesity? What are your surgical options? What are your next steps? So what is obesity? Obesity is a diagnosable disease defined by excess fat storage that increases the risk of health problems and is measured by the body mass index, or BMI. In many cases, effective long-term treatment requires more than just diet and exercise. Obesity can be caused by many factors including genetic, environmental, and hormonal. So how do we measure obesity? With the body mass index, commonly known as the BMI chart. BMI is a measure of body fat based on height and weight that applies to both adult men and women aged 20 and up. Obesity measures begin at a BMI of 30, and morbid obesity begins at 40. There are many factors that qualify a patient for bariatric surgery. One of the key factors is the BMI. According to the national standards and many insurance requirements, a BMI of greater than 35 with comorbidities or greater than 40 without comorbidities are markers for bariatric surgery. According to the National Institute of Health, less than 1/3 of the United States population is at a healthy weight. This is an example of environmental change. Today's lifestyles are on the move, grab and go. The average restaurant meal today is more than 4 times larger than that of the 1950s. This animated slide demonstrates the prevalence of overall obesity in the United States among adults from 2011 through 2019. The yellow states indicate obesity prevalence of 25% of that state's population has a BMI of greater than 30, orange 30%, and red greater than 35%. So now we're going to talk about hormonal imbalance. This brief video, where you are going to meet Amanda, defines the set point.
You might know someone like Amanda. She's a 42-year-old mother with a 6-year-old son. Her baby is just starting first grade, and Amanda looks forward to seeing him grow and enjoy a happy life. But Amanda is concerned she will not live long enough to see him finish high school. She's been struggling with her weight, and in recent years, it has become a serious threat to her health. She is dependent on large doses of insulin for her diabetes. Her joints are so painful that she can barely walk beyond her garden. Amanda has worked very hard to lose weight in the past. She tried many types of diets and worked with weight management specialists to control her weight. Even though she lost some weight with each new diet and exercise routine, the weight always crept back on, and then some. She wanted to lose the weight on her own, but she felt like her body just kept failing her. What Amanda didn't know is losing weight and maintaining weight loss is a lot more complicated than simply eating less and exercising more. Historically, people have believed that body weight is determined by the energy balance equation. If you consume more calories than you burn, you gain weight. If you burn more than you consume, you lose weight. We view obesity as a lifestyle choice, and the cure for it is simple: eat less and exercise more. This assumption may sound logical, but it can be wrong. One theory, called the set point theory, suggests that no matter what you want to weigh, your brain has a certain weight range and body fat level that it works to maintain within the set point range. This means that you don't control your body fat consciously. Rather, your brain manages it like it does your breathing and heart rate. Your brain receives information through hormone signals from your body fat, muscles, pancreas, liver, GI tract, and sensory organs at all times, and controls your appetite, digestion, energy balance, and metabolism. Once your set point has been elevated, your body works to defend it vigorously. What happens when Amanda starts a diet? She might be able to lose some weight temporarily, but hormone signals from her body change in response to weight loss and tell her brain to increase calorie intake and slow down calorie burn to restore the body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning calories slower than before. Amanda's body doesn't recognize that her set point is too high and her weight is unhealthy. It only knows to defend her current set point. Think about her system like a house with a broken thermostat. If the thermostat gets set too high, you might be able to cool the house down temporarily by opening a window, but the sensor would detect the temperature change and heat it up again until it reaches the temperature set by the thermostat. This might explain why treating obesity with diet and exercise so often fails to produce the desired results. It's sort of like telling Amanda to open the window to let some cool air in, when the real problem is that she needs a mechanic to fix her thermostat. Okay, so if the set point system prevents us from losing weight, why doesn't it also protect us from gaining weight and developing obesity in the first place? It actually takes a perfect storm to cause an obesity epidemic. Changes to the chemical and nutrient content of our food, the so-called Western diet, a decrease in physical activity, increased levels of stress, inadequate and disrupted sleep, and more widespread use of medications that affect metabolism and promote weight gain, all appear to play a role in elevated set points and rising rates of obesity. And Amanda responded to those environmental changes by sending hormonal signals that elevate her set point for body fat. What can you do with the elevated set point? Back to our thermostat analogy. Amanda's room temperature was set too high, and she needs to lower her thermostat temperature, or in other words, find a way to lower her set point. She needs to find a way to make her body regulate itself to a new lower weight. One option for Amanda to consider is bariatric surgery. In study after study, it's been shown to currently be the most effective long-term treatment of obesity. So how does bariatric surgery work to help people lose weight and maintain that new lower weight? Most people, even many doctors, think that bariatric surgery works only for restricting food intake or preventing calories from being absorbed. This is true, but there is more to it. Research suggests that certain types of bariatric surgery also affect the signals between the brain and the body and cause decreased appetite, increased feelings of fullness, increased metabolism, and even preferences for healthier food. These surgeries appear to produce signal changes that reset the body weight set point to a new healthier level and stop the brain from encouraging weight regain in response to dieting. Bariatric surgery may also affect hormones that help to regulate your overall health, which may explain why some types of bariatric surgery can resolve or improve type 2 diabetes. So, here are 3 things you can take away from all of this. 1. Body weight and body fat are highly controlled by a complex system. 2. Obesity is a disease where the complex system that controls body fat may malfunction, resulting in a set point that is too high. 3. Bariatric surgery may work by changing the signals that control the body fat set point, enabling patients to successfully lose weight and keep it off for long term. Bariatric surgery is shown to be the most effective long-term treatment for obesity. To learn more about surgical obesity treatment and the journey for a healthier life, visit www.thehealthpartner.com/WLS.
Hormonal imbalance can lead to obesity and is one of the main causes of the disruption and the resetting of the set point. These are all the hormones involved in your metabolism and digestion. What we focus on is the relationship between leptin and ghrelin. These 2 hormones contribute to the regulation of food intake and body weight. Leptin regulates the suppression of food intake and stimulation of metabolic rate to achieve energy balance. Ghrelin is known as the hunger hormone or the appetite stimulator. So let's talk about comorbidities. Patients with a high BMI are at risk for many obesity-related health conditions, which may be improved or resolved with bariatric surgery, including a few of the most common: type 2 diabetes, high blood pressure, high cholesterol, heart disease and stroke, sleep apnea, depression, or metabolic syndrome. Metabolic syndrome is defined as a cluster of conditions that increase the risk of developing heart disease, diabetes, and stroke. These conditions are central obesity, which is measured by waist circumference. This waist circumference is more than 40 inches for men or more than 35 inches for women. High fasting blood glucose, unhealthy lipid levels, and high blood pressure. So what are your surgical options? There are 4 procedures performed for surgical weight loss in the United States: laparoscopic sleeve gastrectomy, laparoscopic gastric bypass, biliopancreatic diversion with duodenal switch, laparoscopic adjustable gastric band. At Sharon Regional Center for Weight Control, we perform the sleeve and the bypass. The laparoscopic sleeve gastrectomy is the most performed surgery in the United States today. Its mean excess weight loss after 1 year is 55 to 60% and has successful remissions of obesity-related comorbidities as patients lose the excess weight in that first year. There are no implanted devices and there is no rerouting of the intestines. The sleeve is a restrictive and metabolic procedure, therefore it will restrict the amount of food you can intake while causing the favorable changes in the gut hormones we discussed earlier that suppress hunger, reduce appetite, and improve satiety. Some risks, complications, and disadvantages specific to the sleeve are bleeding, leak at the staple line. It is non-reversible and non-adjustable. Exacerbation of gastroesophageal reflux disease or GERD. Potential for long-term vitamin deficiencies if recommendations are not followed. This short video is an explanation and animation of the laparoscopic sleeve gastrectomy.
To access the abdominal cavity, small incisions are created. Trocars are placed to serve as passageways for surgical instruments. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes. These help break the food down into a simpler form so that it can be digested more easily and absorbed in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters and is about the size of a banana. The resected portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. Bile and pancreatic fluid from the liver and pancreas mix with food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or postoperative adjustments needed for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
The Roux-en-Y gastric bypass. This is the second most performed bariatric surgery in the United States. The Roux-en-Y gastric bypass is considered the gold standard of bariatric surgeries. It has been around the longest and has the most data collected from it. The first procedure was performed in 1954. With a mean excess weight loss of 67 through 70% after the first year, successful remissions of obesity-related conditions, and no implanted device. Like the sleeve, it is both a restrictive and metabolic procedure. Therefore, it will restrict the amount of food you can intake while causing the favorable changes in the gut hormones we discussed earlier that suppress hunger, reduce appetite, and improve satiety. A few risks, complications, and disadvantages specific to the bypass include, but are not limited to, bleeding, leaks from the staple lines, stricture, ulcers, hernia, dumping syndrome, lifelong supplementation of diet with daily vitamin and minerals, the inability to detect the stomach, duodenum, and parts of the small intestine using X-ray or endoscopy. Should problems arise after surgery, such as ulcers, bleeding, or malignancy. This short video is an explanation of the Roux-en-Y gastric bypass.
To access the abdominal cavity, small incisions are created. Trocars are placed to serve as passageways for surgical instruments. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes. These help break the food down into a simpler form so that it can be digested more easily and absorbed in the small bowel. During a gastric bypass, a small pouch is created in the stomach using a stapling device. The small stomach pouch, about the size of an egg, limits the amount of food you can eat before feeling full. The small bowel is separated into two sections. The lower portion of the small bowel is attached to the newly created stomach pouch. This allows food to pass directly into the second portion of small bowel, where digestion continues. The upper portion of the small bowel is reconnected to the lower. Bile and pancreatic fluids from the liver and pancreas allow food to be digested completely. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
Here at Sharon Regional, we have a comprehensive multidisciplinary team. It is personal and individualized process for each patient. There is the medical director who oversees all pathways and processes of the program, the bariatric coordinator who attends to the comprehensive and quality care the patient should expect to receive. They also assist in the patient's navigation to surgery. The clinical bariatric team. They assist with the bariatric process, immediate pre-op and post-op care, and long-term follow-up. Specialty services. All specialty services available locally for continuity of care. There's nutrition, physical therapy, pulmonology, cardiology, and psychology. Bariatric inpatient care. All patients are admitted to the specified bariatric floor with nurses and staff that are familiar with immediate bariatric surgery patient care. And the operating room team. There's a consistent team to allow for optimal care. Meet Dr. Najawan. Dr. Najawan is the medical director at the Center for Weight Control at Sharon Regional. She has completed a general surgery residency at the Cleveland Clinic in Cleveland, Ohio, and is fellowship trained in bariatric and advanced laparoscopic surgery at University of California at San Diego. Dr. Najawan is board certified in general surgery, and she is a member of ASMBS, ACS, and SAGES. Dr. Najawan is involved in research projects addressing obesity. She has a special interest in metabolic aspect of bariatric surgery. So are you a candidate for weight loss surgery? If you have a BMI greater than 35 with comorbidities or greater than 40 without, healthy enough to undergo a major operation, failed attempts at medical weight loss, absence of drug and alcohol addiction, if you are nicotine-free for at minimum 8 weeks prior to surgery, no uncontrolled psychological conditions, consensus by multidisciplinary team, and that you understand the surgery and the risks. This is our bariatric from seminar to finish line. The bariatric surgery track is a lot of work, and we will go into this with further detail once we've established you in our program on your initial visit. Information seminar. Done. Check mark. Initial consultation with surgeon and coordinator, establishing if you are a candidate for surgery, insurance requirements discussed, the program is compiled for the patient, and tracking is established. Dietitian counseling to establish healthy eating habits and ensure success. This is the focus of our program. You will usually see the dietitian within 2 weeks of your initial consult. Physical therapy consult for exercise counseling. Our physical therapy offers heated aquatic therapy for patients who cannot land exercise. This also establishes the importance of the relationship with exercise and with nutrition. Primary care provider visits as required by insurance, but a minimum of 3 months. Most insurances require your primary care physician to follow you until and after surgery. There are many changes that will happen even preoperatively. Preoperative optimization with cardiology, pulmonology, and psychology. Patients are required to be cleared by these disciplines prior to surgery. In addition, our bariatric patient support group is a private Facebook page you will be invited to after your first visit. After you've had your surgery, you will participate in the following post-operative care. You will see the team at General Surgical Specialist for your 1 week, 2 week, 6 week, 3 month, 6 month, and 1 year post-operative appointments. Then you will continue to see the staff annually. So how to achieve and maintain weight loss? Recovery takes time and patience. The diet is strict and must be followed post-operatively. Remembering the capacity of the food you can and will eat will change. Movement, walking early and walking often is very important. You may experience discomfort and pain as your body heals. The length of time to return to normal activities can vary from patient to patient, but typically starts at 2 weeks. Obesity prevention is a journey and not a destination. Accomplished by setting realistic goals, we can't break an entire box of pencils at once. We need to break them one at a time. Remembering, this is a lifetime of habits we will need to modify and change. There will be many ups and downs, setbacks, but there will be accomplishments and achievements. Forgiving ourselves is sometimes the first big step. So, begin and start making changes today. A few things you can start thinking about now. Cutting back on high-calorie beverages, avoiding fast food, movement and exercise, and being empowered. If you have any questions, please contact us at the office at 724-981-0630. We are excited to be taking this journey with you. Please fill out the information at the end of this seminar, and we will be contacting you as soon as possible.